Oh,
How's it going?
good. Gorgeous out.
Yeah. All right, so there's only a couple more chapters left, right? Between today and tomorrow, I'm going to finish the urinary system and the reproductive system. I've already created the test and posted the test, so after tomorrow, you can take the test. And I forget what day I did the due date on it, but I'll go and look at it, make sure it's, I think I gave you guys till Monday to do it.
Monday,
Yeah,
9,
it was
Monday
9,
at midnight?
9 something. 9
Oh,
o'clock.
9? Oh,
Yeah, it's on 9. I just saw it earlier.
that's weird. It should be midnight.
9:26.
Yep.
They
So
must
that
know when I was
9:30.
creating it at 9:26 at night or something. So I'll change that to midnight. That's fine. So what I plan to do tomorrow is get all your other outstanding grades in. So the homework grades and stuff that aren't in there, I'll put those in so that you have a better idea of what your average is. Right now, I think about 3/4 of the grades are in there. So I'll get the rest of those in there, obviously, except for the last couple assignments that aren't due until after tomorrow.
I have a Pearson question really quick on that note.
Sure.
It's showing the homework for these 2 chapters and the quiz both due today in my
Yeah.
Pearson page.
No.
Is that correct?
I was just going to say something about that.
No, it's
Okay.
not correct. So the homework is usually due Thursday, right?
Right.
And
I wasn't
then
sure if it'd be
and the
switched to
quizzes
the
are
usual.
usually due Sunday. So let me change that for you.
Okay, thank you.
Yeah, no
I
problem.
was like frantically trying to get them all done, but I was thinking it'd be good to hear the lecture first.
Right. Where's okay, so I'm gonna just share my screen and go into Pearson and do that so I don't forget. Go. There we go. Okay, that's better. Other questions before we get started?
I have a question about the grades.
Sure.
I don't know. Last time I took the picture of it because I shared it with my daughter.
Mhm.
And then 2 weeks later, I checked it. It went down. What happened? That's
I don't know. That grade book, sometimes weird things are happening with it, so I have to double check it. Sometimes what happens is I'll add an assignment in a grade and it'll go into the wrong category. And so then when I realize that it should be in a different category and I change it, it changes people's grades. So that could be something. Like I said, tomorrow when I update all the grades, I'll make sure that everything's in the right category. And I think for almost every category, I'm dropping the lowest, like the lowest quiz and the lowest homework and all that stuff. So it should be fine. Whatever your grade is now should be fine.
okay.
But I always like to have the grades in there in the Moodle grade book a couple days before I have to submit it to the college, so that you guys get a chance to look at it and see if there is something like that, something that seems wrong or whatever, so that we can figure out what's going on.
Oh, I also find out that this course is not counted for ANP1.
You have to take AMP1 over the summer, and then you're taking AMP2 in the fall.
Because I changed field. I changed field from nursing to respiratory care.
Yep.
So I have to start all over again from 126 and then 215, which ANP1 and then ANP2.
Gotcha.
This one does count for quite a bit. I think that I know in the LPN one, it was one of the following, and this class was one of them.
Yeah, this is meant for LPN,
Oh, okay.
not for associate.
Gotcha.
Right. The associate's degree, they generally need to take a 2-semester AMP class, which is it's this class, but it's more in detail, right? Because you can go in more depth if you're only doing half as many systems. And that's
Right,
kind of what it is.
but I thought in order to take AMP 1 or 2, that this was the requirement. This or one of maybe 3 other options. No? Okay, I looked at it
No,
wrong.
it's 215, but this is
Gotcha.
equivalent to 215, so I skipped 215.
That's what
Oh.
I guess I meant. Okay.
Oh, no, sorry, 125 rather. This is
Yeah.
meant for 125, then the next level is 126.
It's definitely a little confusing when you look at the.
Mm-hmm. Numbers are confusing.
I also joined a little late, so I probably missed half of what you said because just like you the other day, my computer started an update.
Oh, yeah. I love that.
I love that. Yep. All right.
Okay.
All right. So, urinary system. Urinary system organs are pretty easy, fairly easy. Just in a big, broad picture, what does the urinary system do? Who knows what
Gets
it's
rid of
Excretes waste from the kidneys.
good? Gets rid of waste from the kidneys. Where do those wastes come from? How do those wastes end up in the kidney?
The
Is it from
liver.
the blood and lymph?
The blood, not the liver.
Oh,
the blood.
okay.
No,
Yep.
not liver. I said blood.
Yeah,
and
from the,
No,
yeah, it's,
I said liver. Sorry.
Yep.
Yep.
I kept talking, my microphone was off.
For once, the answer is not ATP.
Right, it's not ATP in this one. So every time your heart beats, about a quarter of your blood goes to your kidneys, and your kidneys filter out anything extra that you don't need. So they're filtering out extra water, extra electrolytes, which are just ions like salts, like sodium and potassium. Anything that is more than what you need gets filtered out of your bloodstream at that point and gets passed to your bladder so that you can urinate that out. So the actual urinary system organs are fairly simple, right? And again, it's just excretion of organic waste from bodily fluids, elimination of these wastes into the external environment. And by doing that, you are regulating the volume and the solute concentration of the blood. So you're getting rid of excess water, you're getting rid of excess sodium, potassium, things like that. So here is an outline or a diagram just showing the organs of the urinary system. Like I said, really simple. Kidneys, 2 kidneys. You have a tube going from each kidney down to your bladder, and those tubes are called ureters. You have the bladder, and then you have a tube leading from the bladder to the outside of the body called the urethra. So what you can see here in red and blue, red is the abdominal aorta, blue is the vena cava. So big picture, this red vessel is bringing blood from the heart, and there are a couple big branches off it that go to each kidney. There's one going to the left kidney and one going to the right kidney. Those are called renal arteries. And they are bringing unfiltered blood, right? They're bringing blood right from your heart. And what the kidney is doing is taking that solution, that liquid, and dividing it into 2 parts. Dividing it into clean blood, quote unquote clean blood, and waste. And so what we'll see is that this red artery is carrying blood in, and a bunch of things happen in the kidney. And the clean blood flows back through these blue veins, back through the vena cava, back up to your heart. But the waste flows through these tubes called ureters to the bladder and gets out of your body. So one volume of fluid is coming in, your kidneys are dividing that into 2 separate volumes. They're sending one volume back through veins to your heart, and the other volume they're sending through the ureters to your bladder. Okay. So the kidneys produce urine, right? Your urinary tract includes the ureters, which go from each kidney to the bladder, which stores urine and eliminates the urine from the body, and the tube that goes from the bladder to the outside of the body is called the urethra. And so in addition to removing organic waste, so organic waste from things that you eat, right? From the breakdown of proteins, let's say you eat food, the proteins get into your bloodstream, you break down those proteins, some of that you can't use, it becomes waste products. It's still in your bloodstream, your kidneys are going to filter that out. In addition to doing that, it's filtering a whole bunch of things that are helping to maintain homeostasis. It's regulating blood volume and blood pressure. Well, it's doing that by getting rid of excess water. Okay, making sure that you have a certain amount of water in your bloodstream. If you are dehydrated, you're not going to get rid of a lot. You're going to hold on to more. If you are drinking a lot of water, your body's going to keep passing that to your urine. You're also regulating concentration of ions like sodium, potassium, chloride, calcium. These are ions that are necessary. You need them in certain concentrations, right? But if you have excess ones, you're going to get rid of that through the urine. And in doing that, this is helping to stabilize the blood pH. You want the blood to be about 7.35, and that's happening because you're getting rid of things like excess bicarbonate ions. And it conserves valuable nutrients like glucose and amino acids, right? So things like glucose shouldn't be in your urine. You shouldn't have enough glucose that there would end up being any of it in your urine. If you do, then that's a sign of diabetes possibly. Okay. So where are the kidneys? I think most of us know where they are. We have two kidneys on each side of the vertebral column. They are between our last thoracic and our third lumbar vertebrae, so our lower back. The right kidney is slightly lower than the left because the liver is there. The liver is kind of in the way, so it pushes it down a little. The position of them is called retroperitoneal. So what is retro? If something is retro, what does that tell you?
Back.
in the
Towards the back.
Yeah, toward the back. So something retro, like we think of retro things from the past, right? It's towards the back. And that's what retroperitoneal means. The peritoneum surrounds your intestines. And so this is behind the layer that surrounds your intestines. It's retroperitoneal. And on top of each kidney is a gland. That's the adrenal gland. We will see the word renal a lot with the kidney. And so the adrenal gland is right on top of the kidney. So here's another view of the kidney, kind of the position of them, showing their position in relation to the ribs and the vertebrae, right? And here is a section, right? A transverse section, and you're looking down. This is a superior view, so you're looking down. You can see things like, here is your fibrous capsule of the kidney. You can see how close it is to the spleen and the stomach, so it's behind the stomach and the intestines. That's why it's retroperitoneal. They are bean-shaped, right? The indentation on one side is called the hilum. The hilum is that indentation where the renal artery, the renal vein, and the ureter all either enter or leave the kidney. Okay, so where those three kind of tubes, for lack of a better word, where those two vessels in the ureter leave and enter the kidney, that's called the hilum. It's kind of just a concave surface. So right here, where those vessels are coming into or leaving the kidney. And the outer surface of the kidney is covered with a capsule that's fibrous. You guys kind of felt that when you did the dissections. So what's going on inside the kidney is actually where all the real anatomy is in this chapter. Inside the kidney is where you filter the blood, and there are millions of little tubules inside each kidney called nephrons. There are more than enough, there's like 1.2 million in each kidney. There are more than enough in one kidney to filter all your blood. You can live on one kidney, okay? You can donate a kidney and be fine just on one kidney. These nephrons are kind of arranged partially in the outer part of the kidney and partially in the inner part of the kidney. And we are going to discuss how they filter the actual blood. So these are the tubules that are filtering the blood. So they're taking that blood and they're dividing it into two liquids, one which they're sending to your bladder and the other which they're sending back to your heart. So to get to that point, we first have to talk about the anatomy of the kidney, which is this figure on the left. So you can see that this part of the kidney is called the hilum. You can see it circled here. That's where the ureter is going out of the kidney. That's also where the renal artery and vein are coming in. They're not shown on this diagram. The kidney itself is divided into a cortex and a medulla. Right? The cortex is the outer part. The medulla is the inner part. So the cortex is this kind of light, I don't know, it looks like a tan color, this outer part. So everything from these red and blue vessels up towards the outside is the cortex. Everything from those vessels down towards the middle is the medulla. And in the medulla, you have these triangular shapes, which are purple in this diagram. Those are called the renal pyramids. Here's the label right here. Okay, they look like a pyramid, they're triangles. The filtering actually takes place as this blood is flowing through the pyramids. Now, in between each pyramid is a area of tissue called the renal column, right? That's just the area in between each of these triangles. And so as blood is filtered, it's moving, it comes into the kidney, comes all the way to the cortex, and it's going to travel down through a renal pyramid, right? As it's traveling down through that renal pyramid, it's getting filtered. And so the movement of the filtrate, the stuff that gets filtered out of the blood, that's going to pass to your bladder to become your urine, that's moving through this renal pyramid. It's leaving the renal pyramid and going into this space called the minor calyx. And several minor calyces, right, more than one, ends up coming together into what's called a major calyx. So you can see this is two minor calyces coming together to form a major calyx. And the major calyces all end up in the renal pelvis. Okay, and whatever's in your renal pelvis ends up traveling down the ureter to go to the bladder. So that is the flow of the waste product. It goes through the renal column, through the minor calyx, through the major calyx, through the renal pelvis, to the ureter. The thing that is in these pyramids that does the actual filtering is called the nephron. Here's the nephron. Okay, they show one purple nephron here. They've drawn it in over here on the left. There are millions of them in each kidney. The nephron itself has a bunch of parts to it. It's a tubule, and there's a bunch of names to it. The tubule always starts at this rounded area. This rounded area is called the renal corpuscle. Right here. And then the tubule coming off of the renal corpuscle is the proximal convoluted tubule. Then it goes down and back up. That part that goes down and back up is called the nephron loop. Then there's another kind of curly piece called the distal convoluted tubule, which leads to a collecting duct. Now, the words proximal, distal, what do they tell you?
Closer and further
The
apart.
okay.
Good, closer and further away. Is proximal closer or further away?
Closer.
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 So the proximal convoluted tubule is the end that's attached to this renal corpuscle. It's closer to that corpuscle. The distal convoluted tubule is further away from that corpuscle. It's actually attached to the collecting duct. Okay. So what we will see is that the waste moves all the way through this. It moves from the renal corpuscle through the proximal convoluted tubule down the nephron loop, back up the nephron loop, through the distal convoluted tubule to the collecting duct. Now you can see there are other nephrons that would actually connect to the same collecting duct, right? Which they're not showing them here, but you can see where they would connect. You can see that that collecting duct goes right to the end of one of these renal pyramids. So this space right below the purple collecting duct, that's a minor calyx. Okay, that would be the same as one of these, which would lead to a major calyx, the renal pelvis, the ureter. So whatever is coming through this collecting duct ends up as your urine. Okay, so now we know that it's going collecting duct, minor calyx, major calyx, renal pelvis, ureter. Okay, we're not quite there yet. The other piece to this is the blood supply to the kidneys. Now, I said that every time your heart beats, right, about a quarter of your heartbeat goes to your kidneys. And so there are these arteries that flow into your kidneys carrying the unfiltered blood to the nephron. The nephron's going to filter that blood. Whatever it filters out, it's sending through the collecting duct, right, to go to your urine. Whatever is clean, the clean blood is going to go back through veins to get back to your heart. So you have to know the blood supply and you have to know the parts of the nephron, and they will come together in a few minutes here. I'll show you where they come together. So right now it seems like a little bit disparate, but you'll see hopefully where it comes together. So over here on the left, they're showing the blood flow, right? And they've enlarged one of these renal pyramids for you. So blood is coming in through the red renal artery, right? And it branches into smaller branches called segmental arteries, which branches into even smaller branches called interlobar arteries. You can see that that's labeled here on the left. The interlobar arteries kind of go up in between each of the pyramids. And then from the interlobar arteries, it goes to what are called arcuate arteries. Arcuate arteries are these ones that kind of separate the cortex from the medulla. And from the arcuate arteries, it goes up through cortical radiate arteries. Now, these are only in the cortex. They're cortical, right? So these are the little red arteries that are sticking up. So over here, they've enlarged one renal pyramid. You can see the interlobar artery is what is going in between the pyramids. Here's the arcuate artery. Off the arcuate artery, you have the cortical radiate arteries. Those are these vertical ones going up. Off of each of those cortical radiate arteries are a bunch of these little, there are afferent arterioles. They look like these little round circles. Right? That round circle there represents this renal corpuscle. It's the blood coming into this circular part of the nephron. Okay. Stick with me for a minute. It's going to hopefully make sense in a minute. So here's what happens. Let's look at C here, picture C on this slide. So we've just looked at picture B. We've just looked at the blood. So remember the blood, the unfiltered blood is coming through these red arteries, the interlobar arteries, the arcuate arteries, the cortical radiate arteries, the afferent arterioles. Well, look where this afferent arteriole leads. It leads into that purple renal corpuscle, that cup, that circle. When it leads in there, it branches into a bunch of capillaries. There's a little capillary network inside that renal corpuscle. And that capillary network is called the glomerulus. You see the word over here. Glomerulus are the actual blood capillaries within the renal corpuscle. Now, what we know about capillaries is that they have really thin walls. So what happens at the glomerulus is things are filtered out of the blood, okay? Different salts, water, glucose, almost everything is filtered out of the glomerulus at this point. What gets filtered out ends up in this purple tubule. It gets squished. Think of it getting squeezed out of the capillaries. It ends up in this purple tubule. This purple tubule is the renal corpuscle of the nephron. In that renal corpuscle, that fluid that got filtered out of the blood is now going to travel through the proximal convoluted tubule, down and back up the nephron loop, through the distal convoluted tubule, and end up going to the collecting duct, right? So your blood, your unfiltered blood's coming in here. The renal corpuscle is squeezing it, squeezing all those nutrients out of it, squeezing everything out of it. And all those things that get squeezed out are going to travel through this purple nephron, right? And the end of that purple nephron is a collecting duct, which eventually leads to the bladder. But the problem is the nutrients and everything that's in the blood, in the glomerulus, everything gets filtered out. Too much gets filtered out. So too much water gets squeezed out. Too many ions get squeezed out. Too much glucose gets squeezed out. And your blood says, well, wait a minute, I need some of that. I need potassium, I need sodium, I need water. I need some of that. So what you have leaving this, these glomerular capillaries, and I'm sorry, here's my cursor. What you have leaving these glomerular capillaries is an efferent arteriole, right? So blood's coming in through the afferent, leaving through the efferent, and see how it wraps around this nephron. The reason that these capillaries are wrapped around the nephron is because as the fluid is flowing through this purple nephron, the capillaries are reabsorbing a lot of the nutrients, right? Your blood is saying, wait a minute, you squeezed out too much. You got rid of too many things that I need. So as that fluid is moving through this purple tubule, your capillaries are reabsorbing a lot of that fluid. Now the capillaries themselves, you have an afferent arteriole, which brings the blood into the nephron. You have an efferent arteriole, which brings the blood out of the nephron. And this network of capillaries, these are called peritubular capillaries. Peri means surrounding, so they're surrounding the tubule. So in the peritubular capillaries, you're reabsorbing a lot of what got filtered out. You're reabsorbing things from the nephron. And you're only reabsorbing what you need, right? So if you got rid of all of the sodium, you're only taking back up the sodium that you need. If you got rid of all of the water, you're only taking up the water that you need. Whatever is taken back up, if we look, these red capillaries turn to blue. That's what ends up being the clean blood that's going back to your heart. Okay, whatever's in these capillaries that has taken up the nutrients that you need ends up going back to the heart. Whatever is still left in this purple tubule, in this nephron, travels down the collecting duct to become your urine, the excess, the extra ions, the extra water. So the blood, the clean blood, then flows through this blue little vein called the venule, right? And it flows through, I'm going to go back to the blood. It flows back through cortical radiate veins, back through arcuate veins, back through interlobar veins, and back to the renal vein. Okay, and the renal vein connects back to the inferior vena cava, which goes back to your heart. So the renal artery is bringing blood in, the blood is traveling to the cortex, and then it comes down through all these renal pyramids. And as it's coming down through those renal pyramids, filtration is happening in those nephrons. The clean blood is then flowing back out through all these blue veins. What gets filtered out ends up going through the ureter and going down to your bladder. All right.
So what your body,
Questions?
yeah, sorry. So what your body questions, like you were saying before, like where's the water, salt, glucose, all of that, that turns into urine?
What I missed the
That makes-
last half. You're kind of
So
cut out a
you were
little.
saying that the body will then question, like, where is all of this stuff? Where's the salt? Where's the water?
Mhm.
Where's the glucose? That
Mhm.
becomes urine? That fluid that the body is questioning, where all the...
Right. So the excess. So what is not reabsorbed by these peritubular capillaries becomes the
Mhm.
urine. So right here in the beginning, too much stuff gets squeezed out. And then
Right,
as it's moving through this tubule, you're reabsorbing stuff. So whatever doesn't get reabsorbed is what gets passed to the collecting duct. So it would be excess sodium, excess potassium, excess water, for example, goes to the urine.
okay,
And that's how you get rid of it. So you're not really filtering out necessarily toxins, right? But it's just kind of regulating the amounts of different ions that you need, and the amount of water, the amount of fluid that you need.
okay, all right. Thank you.
You're welcome. So you kind of, I mean, you need to see the flow of blood along with understanding what's going on with the nephron to understand what the kidneys are doing. And you can get into a lot of detail with this. It's known and documented, like at what points within this nephron do things get reabsorbed. And we're not going to go into that much depth in this course or anything, but that is all known. What this picture here shows are two different nephrons. So C and D are two different types of nephrons. They both do the same exact thing, but notice that the picture D has a much longer nephron loop. So most of our nephrons are like picture C. And those are called cortical nephrons. And they're called cortical because they mostly reside in the cortex. This loop may go down into the medulla a little bit, right? But see how this one is drawn over here? It's mostly in the cortex. Most of our nephrons are like that. About 85% are like that. But we have some nephrons that have a really long loop that dips way down into the medulla. Here's one that's drawn here, right? Those are called juxtamedullary nephrons because they actually juxtapose both the cortex and the medulla. So there's only about 15% of those. They do the same things, okay? But they reabsorb nutrients at different rates because of the length of the nephron loop. But as far as what they're doing, they're filtering your blood. They're doing the same exact thing. It's just the longer loops are allowing you to reabsorb a different amount of nutrients. That's all. So you need to know that flow of blood, I'll go back to this one, right? It comes in through the renal artery, which branches into segmental arteries, which branch into interlobar arteries, which run between the renal pyramids, which branch into arcuate arteries, which are the ones that separate the cortex from the medulla, which branch into cortical radiate arteries, which are the ones that run outward into the cortex. And at that point, they're bringing blood to the nephron, right? So afferent arterioles are actually bringing the blood into the individual nephrons, and they branch into glomerular capillaries in the nephrons. And then leaving the glomerular capillaries are efferent arterioles, and those turn into peritubular capillaries that surround each nephron. And then the clean blood from the peritubular capillaries flows back through cortical radiate veins, arcuate veins, interlobar veins, and back to renal veins. So they have the same names as the arteries, just flowing the other way. Questions?
So from the efferent arterioles, that's the clean blood at that point?
No, it's not clean until after it leaves the peritubular capillaries. So,
Oh, okay, all right.
so you've got the unfiltered blood coming in the afferent arteriole, right? A bunch of stuff, too much gets squeezed out in the glomerulus.
Yeah.
And so you still have like red blood cells and some of what didn't get squeezed out in the efferent arteriole. And then as it's traveling through peritubular capillaries, you're reabsorbing a lot of the water, the glucose, the ions. And so by the time it gets to this, where it's blue here, by the time it gets back to the cortical radiate veins, then it's filtered. It's clean blood at that point.
I always say that wrong too. It's efferent. I have to remember that.
What's that?
I always
Oh.
say it wrong. It's efferent.
So
I
I
always say-
overpronounce it just because I try to,
So
in
it's
my
not the
mind,
same
I
for
try to remember afferent and efferent. It's kind of like,
That makes sense.
yeah, it's kind of like affect and effect.
Yep.
right? They
Yep.
mean two
Another
different
fun
things.
one.
Yeah, so I just try to overpronounce it so that it doesn't get as confusing. So the afferent always means running towards something, and efferent means running away from something, right? So afferent is going towards the corpuscle, and efferent is going away from it.
So the efferent is the one leaving, right?
Correct. Efferent
Yeah,
is the one
'cause-
leaving the corpuscle.
Yeah, because I know for some reason I have it in my head, E for exit,
There you go. Absolutely.
so that I don't get confused.
Yep. Absolutely.
That's very helpful. Thank you,
You're welcome.
Julia.
Yeah, Julie,
And-
that's
You're
You as
welcome.
well. Yeah, both of you. I definitely kept mixing those up.
yeah.
Mnemonics are amazing. They really are.
Yeah, exactly.
Like that.
Yeah. Okay, so any questions about that? Then basically whatever's left over in this tube, whatever doesn't get reabsorbed by the capillaries, is what travels down the collecting duct, through the minor calyx, through the major calyx, through the renal pelvis, through the ureter, become urine in the bladder. Okay, so the nephron, we already went through this, right? We already went through the parts of the nephron, the renal corpuscle, the proximal convoluted tubule, the nephron loop, the distal convoluted tubule, and it connects to a collecting duct. Now, what you can see here is the flow of filtrate and water. We're going to get to that in a second. So don't worry about the flow right now, right? Just understand the names. The renal corpuscle is just that rounded part of the nephron. Sometimes it's also called Bowman's capsule. And the network of capillaries within it is the glomerulus. So the glomerulus are the actual blood vessels. The glomerular capsule, or Bowman's capsule, is the nephron surrounding the capillaries. So again, this is just a close-up of the renal corpuscle. You can see I lost my cursor, here we go. The afferent arteriole bringing blood in. These are the glomerulus. There's the efferent arteriole leaving. Okay. So what I want to do is get through these 3 nephron processes. So there's 3 steps to urine formation. And that's what these 3 processes really are. The first step is filtration. Okay. Filtration occurs in the renal corpuscle. So the first thing that happens is too many things get squeezed out of the blood, right? That's kind of at that first step, at that rounded part. I go back to here, right at this renal corpuscle, right at the beginning, too much gets filtered out. That is the first step, and that is called filtration. Then the bloodstream, your body realizes, I need some of that stuff back. You can't filter all of that out. I need some of that. So the second step is called reabsorption. And what's happening is the capillaries are reabsorbing a lot of those nutrients. It happens mostly at the proximal convoluted tubule. So that's the part of the tubule that leaves or is closest to the corpuscle, right? That first part of the tubule, that's mostly where you're reabsorbing a lot of the water, a lot of the solutes that you've lost. Then there's a third step, which we didn't really talk about yet. The third step is called secretion. And this is allowing for things to move, molecules to move from the blood to the nephron. This is occurring mostly at the distal convoluted tubule. Okay, this is happening at that far end of the nephron, the end that's closest to the collecting duct. And it's kind of like, you can kind of think of it almost as a fine-tuning step, right? The first step, too much gets filtered out. The second step is almost like you reabsorb too much. The third step is secretion. We have to balance that out, right? We have to balance out what's been reabsorbed and what hasn't been. And this secretion is kind of like your body's last chance to get anything out of the bloodstream to pass it to your urine to get rid of it. A lot of what happens here, right? You're fine-tuning the regulation of water, sodium, potassium. This is actually where you get rid of a lot of your medications and things like that as well. They'll get out of your bloodstream at this end of the nephron, the distal convoluted tubule, which means they're going to go into that collecting duct to go to the ureter, right, to get to the urine. So these three processes are the three steps of urine formation. Filtration, too much stuff gets filtered out. Then reabsorption, you're going to reabsorb because your body says, well, wait a minute, I need to hold on to that stuff. And then you're going to kind of fine tune it. You're going to secrete some things from the bloodstream back to the nephron, sorry, in the distal convoluted tubule. This is happening in, all 1.2 million of your nephrons every time your heart beats, right? This is happening to try to control the levels of these different solutes in your blood. Okay, and here are some normal lab values for solutes in urine and plasma. So when you go to a doctor, what's one of the first things they ask you to do when you go in there?
Pee in a cup.
Pee in a cup. And it's because they can tell a lot from the urine, right? There are normal lab values for the solutes in the urine and in your plasma, right? They could draw blood and they could look at what's in your plasma as well. But it's a lot of times easier and certainly less invasive for them to just analyze what's in the urine, because if certain levels of ions are really high or really low, or things like glucose are high, then those are signs that something else is going on, right? If you look here, there's a very small amount of glucose in your urine. If there's a high amount of glucose in your urine, then that indicates that there was a lot of glucose in your blood, which is an indication of diabetes, because your body's not storing it correctly. There should be no proteins in your urine. If there are proteins in your urine, that could be a sign that you have really high blood pressure, and it's forcing some of those proteins out of your blood vessels. So there's a lot of different easy things that people can tell from your urine, that doctors can tell from the constituents of your urine, about your health or about what might be ailing you. Okay, same thing, nitrogenous waste. You're going to have a lot of nitrogenous waste, particularly urea in your urine. That's from the breakdown of proteins, usually amino acids. Questions about any of that stuff? That's the bulk of this chapter. I mean, we'll go through a few more things, but the bulk of this chapter is really knowing the blood flow through the kidney and the steps or the parts of the nephron, and then the flow of the waste from the nephron to the bladder.
I have a question.
Sure.
I heard this before. They said when we take vitamins, we just pee all those vitamins.
Mhm.
That's why the urine turns like yellow.
Yep. So, I mean, there's a lot of different studies that show that your body can't really absorb and hold on to like certain vitamins. They just end up passing through your body, through your system. There's a lot of evidence that like certain vitamins need to be taken with other you know, with other nutrients, they need to be absorbed into fats first. Like there's certain things, certain vitamins, excuse me, that you can get from eating meat because the vitamin is absorbed through the fat and the meat and everything else. There is a lot of evidence for that, so that a lot of these vitamins that you take, that many of us take, multivitamins and stuff, actually get excreted into the urine. So the kidneys actually just excrete them into the urine, and they don't do a whole lot of good in us. There's also, I think there's a study, I think it's on Centrum, that you can find, where the kind of the filler that binds the capsule together doesn't dissolve in your intestines, and so you can just watch it like on a camera go through your intestines, and you don't really get anything out of it. So there's not a lot of evidence that vitamins do a whole lot for you, because
Right.
they're not really regulated, and there's not really a body that studies, you know, which vitamins are better or which ones are approved and which ones aren't. That being said, I don't think they're a bad thing either. Just something that you have to think about and you know, consider when you're considering the cost of purchasing vitamins. How much good are they not necessarily doing?
Right. Yeah, I read before the omega 3.
Mm-hmm.
Is it the one from the fish, right?
Mhm, mhm.
Taking by itself is ineffective. You have to take it with omega 6.
Oh, really?
Yeah, it balances it out. They work together. So
And there's a lot of things like that. Like if you were actually eating salmon or whatever, you know, you wouldn't have to worry about those ratios as much. But when you're,
Right.
you know, when you're taking it in vitamin form, it's like, well, how much are you getting? How much can your body absorb from that?
right.
Yeah.
Okay, thank you.
You're welcome.
So what about the color of our urine? Like if it's
Mhm.
darker, it's a sign of dehydration. Why would that be?
Sure. So yeah, if you're dehydrated, right? We all know if you're dehydrated, when you pee, it's dark colored. If you're drinking a
Yeah.
lot of water, it's like clear.
As far as what happens in the kidneys though, before it's, yeah.
Mhm.
That's what I'm
So
curious about.
so think about what's happening, right? Your body, there's a homeostasis point. There's a point that you're supposed to have a certain amount of water in your blood. And if you're drinking plenty of water, if you're drinking water all day long, then your blood is pretty well hydrated. What your kidneys are doing is letting that water pass to your bladder, right? Because they don't need to hold on to it, because you have enough. When you're dehydrated, if you haven't drank enough water, or if you're, you know, in an environment where you're sweating or whatever, you're losing a lot of water, then your kidneys are going to hold on to almost every drop of water that you drink. And they're not going to pass it to your urine, right? So as that fluid's moving through your nephron, your capillaries are going to reabsorb all of that water that they can. And so what's happening is now that's not getting passed to your collecting duct to go to your urine. So your urine is actually more concentrated, right? There's more solutes in it, there's more salts in it, things like that. So it's a darker color, right? That's the reason that it's either, you know, darker if you're dehydrated, or clear if you're well hydrated.
So at that point, when there's a lack of water in your collecting duct and your body does the whole thing like you're talking about, like, you know, I need more to reabsorb, the whole checks and balance sort of part of it.
Mm-hmm.
Does that trigger something?
What's that?
Would that trigger something at that point? Like, you know, that your body's dehydrated? I don't know how to ask it. I don't know if you know what I'm saying.
Yeah, so it's a big complex mechanism that ends up with hormones and stuff. So
Yeah.
if you remember way back to the endocrine system, there's a hormone called ADH, antidiuretic hormone.
Oh, right.
So
Okay. Yeah.
when you're dehydrated and when you don't have much salt, it triggers you to feel thirsty,
Yeah.
and it causes you to produce ADH. And ADH actually causes the collecting ducts to be more permeable to water, so that water can get from the collecting ducts back into your blood, back into your body. And so if you are doing something which inhibits ADH, then you're going to do just the opposite. So there's all kinds of things that play into this.
Right.
And it's crosstalk with all these different systems of your body.
Right. But that's one of the points that it would be triggered. That you know, that,
Right.
you
Yep,
hydrate.
absolutely.
Yep.
Yep.
Okay. Yeah,
Yep,
it
if
is
you're-
very complicated. It's so hard to ask the questions sometimes because I know what I want to know. It's just I don't know how to say it.
Right. No, and it's a very complex. I mean, it
Yep.
involves aldosterone and it involves ADH.
Yeah.
And then, you know, we all do things which inhibit ADH or which inhibit aldosterone or which, you know, so
Right.
like coffee is a potent inhibitor of ADH.
Yeah.
So you've got this whole mechanism set up so that when you're dehydrated, your body realizes it needs to reabsorb more water, right? It needs to hold on to more water. But if you're drinking a lot of coffee, you're
Mhm.
inhibiting that system.
Yeah.
So if you're drinking a lot of coffee, you're peeing a lot of it out. Your body's not holding on to that water. You're going to start to feel dehydrated after a while.
Yeah, and it
It
lets
doesn't
us know by
hydrate.
creating darker urine. Yep.
Right.
Yeah.
Same thing with
It's supposed to let us know that way anyway. If anybody.
right. Well, the same thing. Alcohol is a potent inhibitor
Right.
of ADH. So, what happens when you drink a lot of alcohol? You end up having to pee a
Have
lot,
to urinate more. Yeah.
and you're peeing out more than you should. Right, your body's not holding on to water, and
Yep.
so the reason you feel hungover the next day is because you're dehydrated.
Yep.
You know, you didn't hold on to enough water. So it doesn't really matter how much, you know, how many glasses of water you drink in between your beers or whatever. Your body's not going to hold on to that water.
Or how much water is in the process of making beer, like some ignorant people.
Right. Exactly. That's light. It's light beer. It's mostly water.
Yeah, exactly. Yeah. Mostly water. All right, thanks.
All right. So GFR is glomerular filtration rate. That's the amount of filtrate produced in your kidneys per minute. Average is 125 mils per minute or 180 liters per day. Over 99% of the filtrate is reabsorbed in the renal tubule. So that's a crazy amount. So stop and think about this for a second. 180 liters a day. That's like 45 gallons a day of liquid that your kidneys are filtering. So your kidneys are filtering about 45 gallons of liquid a day. Now we only have, 10 pints of blood in our body. We only have 2.5 gallons of blood in our body, right? So that's huge. And 99% of that gets filtered. So this is what gets filtered in step 1. 99% of that gets reabsorbed, right? So that you're not losing gallons of water a day. And so this rate, there's a bunch of different things that can affect this rate. And a couple of them are maintaining adequate blood flow to the glomerulus. So, being able to get that blood into the nephron to start being filtered, and maintaining adequate net filtration pressure. Maintaining high enough blood pressure that it squeezes things out. The only reason that filtration happens in that glomerulus is that blood pressure is high enough that it squeezes things out of your capillaries. That's it. If your blood pressure gets really low, your kidneys can shut down because all of a sudden they're not filtering anything out of your blood. If your blood pressure is too high, you can filter out things like proteins, which shouldn't get filtered out. They're too big. They shouldn't get squeezed out. So a big part of maintaining this rate, this constant rate, is your blood pressure.
And is that why proteins are in your urine if you have hypertension or preeclampsia when you're pregnant? Is that?
Yep, absolutely. So the proteins are pretty big, and the pores in the capillaries, the holes in the capillaries, are small.
Mhm.
And so usually the protein shouldn't make it out those holes. But if you squeeze really hard,
Yeah.
you can push those proteins out. And that's essentially what's happening when you have high
When you
blood
have high
pressure,
blood
or
pressure. Yeah.
like you said, preeclampsia is just due to pregnancy, really. It goes away.
Yep. Okay.
My wife was preeclampsia, which is a
I
pain.
was too. It was so scary.
Yeah,
my
it
mom-
is. It is
yeah.
really scary. All of a sudden your blood pressure is really high and your heart's racing, and
I was on bed rest for Christmas. It was a lot of fun.
oh.
Yeah.
I guess
I had him on the 29th.
that's better than the middle of summer when it's
Well,
hot.
that's true. That's true.
But still, that's about the only saving grace.
Yep.
Okay, and then this slide is events at the proximal convoluted tubule. So remember, the proximal convoluted tubule is close to that glomerulus. This is step 2 of urine formation. This is where you're reabsorbing most of those nutrients. At this point, 60 to 70% of what got filtered in step 1 gets reabsorbed. Okay, right at that first part of the tubule, right at the first part of the nephron. This is where all your glucose gets reabsorbed. All your amino acids get reabsorbed. All the other organic nutrients are reabsorbed. You shouldn't really have any glucose or amino acids in your urine. At this point, osmotic pressure pulls water out of the tubule by osmosis. We'll talk about that in a minute. But you're actively reabsorbing a lot of these ions. You're actively reabsorbing ions in relation to what hormones are being secreted. And a lot of that has to be due to what's in your bloodstream, like how much calcium is in your blood, that sort of thing. There is some active secretion that occurs in the proximal convoluted tubule as well. So there are some things that are still moving from your blood to the tubule in this point, like hydrogen ions. But for the most part, the bulk of what's happening in the first part of this tubule is that your bloodstream is reabsorbing these nutrients. Okay.
Can I ask
Then
a quick
as,
question?
oh yeah, go ahead.
With that happening towards the end with the reabsorption of all those different things, do those different pieces like amino acids, nutrients also get their own filtration, like as they go, because they're in the blood that's being filtered? I don't know if that makes any sense, but do you know what I mean? Like the individual components, are they getting filtered?
I'm not sure if I know what you mean.
Like before they're reabsorbed, like I get a lot of them are excreted like too much and then they're reabsorbed at the end.
Oh, so is there a mechanism counting like cleaning the amino acids before you reabsorb them? Is that what you're asking?
Yeah, I'm wondering if like, are they reabsorbed at the end of the process because they need to also go through like kind of checks and balances to see if there's like weird stuff in there?
No, so this is remember, this is the proximal convoluted tubule. So this is kind of at the beginning of the process.
Oh,
So,
beginning. Okay.
yeah, so step 1, too much gets filtered out, and that's just indiscriminate. That's just due to your blood pressure squeezing, right? And it squeezes a bunch of crap out of your blood. And your blood says, well, wait a minute, that's not good. And so your blood starts just reabsorbing and almost just randomly reabsorbing, like just as long as the proximal convoluted tubule is, you're just going to keep reabsorbing, right? It's not due to anything else. It's just due to how fast that fluid is moving through that tubule, right? That you're getting a chance. The whole time it's in that tubule, you're reabsorbing these things. That's it.
Okay, got it.
And then eventually the stuff in the tubule moves down that nephron loop, right? It moves down and back up that nephron loop.
Mm-hmm.
And when it's doing that, a lot of what you're doing is you're moving water and a lot of the sodium and chloride in and out. And so I'm not going to get into how this happens. There's a lot of big, long explanations about this. But this is a lot of where you're reabsorbing the water. And kind of the longer that loop happens to be, the more time you have to reabsorb a lot of the water. And it's actually actively pumping things like sodium and potassium into the tissue around it. And it's creating this concentration gradient in the medulla, which helps you reabsorb more water. But basically what you need to know is as things are traveling down and back up that nephron loop, your bloodstream is reabsorbing a lot of water.
And that water follows salt, right? Is that also
Right, exactly.
Okay.
And then we get to the end of the tubule, that's the distal convoluted tubule. This is kind of where step 3 kicks in, right? This is where that secretion going back the other way from your bloodstream to your tubule. At this point, 80% of your water and 85% of the solutes have already been reabsorbed. So you've already done most of that reabsorption, but you're going to make some final adjustments in fluid composition and concentration. So for example, if you have too much sodium, right, you're going to secrete sodium out back into the waste product, that kind of thing. And this is based on things like the presence of a hormone aldosterone, which will increase your sodium retention. It'll help you reabsorb the sodium. And then water reabsorption, a lot of that happens in the the distal convoluted tubule, the end there in the collecting duct, if you don't have antidiuretic hormone around, you can't reabsorb water. This end of your nephron and your collecting duct are impermeable to water, so water doesn't get reabsorbed. It'll stay in that tubule and get get excreted, pass it to your urine. If you have ADH, that means you're dehydrated, you need water. What happens is the end of that nephron, the distal convoluted tubule and the collecting duct, allow for water to get reabsorbed into your body. And so your urine is more concentrated, it's darker in color. So here is, let's do this one. Here is up here, the tubule permeabilities and the osmotic concentration of urine without ADH. So normally, if you don't have any ADH present, if you're drinking plenty of water, right? Step one, here in the glomerulus is filtration. That's where things get squeezed out. Proximal convoluted tubule is where you reabsorb a lot of things. At this point, we're not going to talk about going through this countercurrent mechanism, but water's coming out, and then as you're going back up, sodium and chloride are coming out, and so water's coming in. But what's happening is the water is here. The water is in your collecting duct and in your distal convoluted tubule. If you don't have any ADH around, that water is going to go to your urine. That's why if you are very well hydrated, you don't produce ADH, and your urine is clear, right? There's mostly water in it. However, if you do have ADH around, if you are dehydrated, by the time you get to this end of your nephron in the distal convoluted tubule, your body is going to reabsorb a lot of water. Water can get out of the nephron at this point and get back into your bloodstream. And so what will happen is your urine will just be a smaller volume, and it'll be a lot more concentrated. You can see there's a lot more black dots in here, and the black dots are representing the solutes. And so that's going to actually cause there to be more solute in your urine, and it will be a darker color.
Just to refresh my memory, that last one that you showed, is a hypertonic. Is that the same thing? Is this like a hypertonic osmosis? Is it the same sort of idea, or?
So,
because that's just what it reminds me of. So I wasn't sure if that's
right. So it's not really hypertonic or hypotonic. If you have a lot of solute, then I guess this solution inside the collecting duct would be hypertonic. But hypertonic and hypotonic are usually only related to
cells.
To cells, right?
Okay.
And so not necessarily the whole tubule.
All right. Okay. When I saw the arrows, I was like, I wonder if that's like the same idea. Okay.
Exactly, yeah.
Okay.
And so here again is a summary of the kidney function. Again, step one is filtration. Too much stuff is squeezed out. Step two, reabsorption. Step three, this is mostly secretion. And then you can see whatever is remaining in the distal convoluted tubule and gets into the collecting duct is what's going to become your urine. Okay, so then we get into all these different mechanisms, right? If your blood pressure drops, or if your blood volume drops, like if you're injured, it triggers this whole renin-angiotensin-aldosterone system. All of these things, what they're going to do is they're going to cause you to retain water and to retain sodium through all these different mechanisms. So what's going to happen is you release renin, which converts angiotensinogen to angiotensin, which converts angiotensin 1 to angiotensin 2. Basically what happens is it constricts all your blood vessels to increase your blood pressure, and that is going to increase your glomerular filtration rate. You're squeezing your blood vessels, which is going to cause you to squeeze out the filtrate more, right? To squeeze the blood out at the glomerulus more. It also releases ADH because it's going to cause you to reabsorb more water, which is going to allow you to hold on to more sodium, which is going to in turn increase your blood pressure again. Okay, and here's a whole big long thing about the response to a decrease in glomerular filtration rate. So GFR is how fast things are getting filtered out of your glomerulus. If that drops, if that filtration rate drops, your body's going to quickly go through a bunch of mechanisms to try to increase your blood pressure so that you're still actively filtering things out of your blood. One of the things that happens is the release of ADH. Again, if you have a drop in blood pressure, one of the ways to counteract that is to increase your retention of water, which is going to increase the volume of blood, which will increase the pressure that's in your blood vessels. And so this ADH has two key effects. One is that it increases permeability of water, or DCT to water, I should say. And we talked about that. We showed that in a few slides. It also stimulates thirst, which leads you to intake more water. So not only are you holding on to the water that you have, but it causes you to drink more water, try to get more water into your body. When angiotensin II is secreted, it's going to also cause the secretion of aldosterone, or when you have too much potassium in the blood. And the key effects is that you're going to reabsorb sodium, which raises your sodium blood levels, or secrete potassium. So if your potassium levels get too high, what you want to do is hold on to sodium and get rid of potassium. This is also going to cause you to retain more water, because if you're holding on to sodium, your water is going to follow sodium. And then ANP is the opposite of those others, right? So those others are released in response to low blood pressure. If you have a rise in blood pressure or blood volume in the heart, you're going to release ANP, which is another hormone. And it's going to do the opposite. It's going to lower your blood volume and your blood pressure. So it's going to inactivate that whole renin, angiotensin, aldosterone thing. This is working the opposite of that, right? This is working the opposite of that other system. You're trying to lower your blood pressure, not increase it. It's going to decrease the rate of sodium reabsorption. So you're not holding on to as much sodium. You want to lower your blood pressure. This is more common, at least in this country. And then we always get to, right, we're talking about organs, we're talking about things that are autonomic, things that we don't think about. And so you've got sympathetic and parasympathetic activations. So sympathetic, remember, is fight or flight. So when you perceive something as a threat, it triggers the sympathetic reaction, which is actually going to constrict your afferent arterioles. So it's squeezing down on those arterioles that are supplying blood into the nephrons. This is going to decrease glomerular filtration rate and slow the production of the filtrate. So what you're doing is you're kind of clamping down how much blood is getting into that glomerulus, and so not as much filtration is happening. The reason you do this is that you're shunting blood away from the kidneys and redirecting it to tissues and organs with higher needs. This is a fight or flight response, right? In fight or flight, your body doesn't care about your digestive system. It doesn't care about your urinary system. What it cares about is getting blood to the muscles so that you can get ready to flee, right? It's shuttling all that blood. Instead of shuttling blood to your kidneys, it's limiting how much is going to your kidneys and sending more blood to your muscles. It's doing things like dilating your pupils so that you have a lot of light coming in so that you can see different things, right? It's heightening all the things that you might need to either flee or fight something. So it's increasing blood flow to skin and muscles, while it's decreasing blood flow to your kidneys or to your digestive system. Okay. So what is kidney failure? It's just the inability of the kidneys to maintain homeostasis. So if your kidneys aren't working properly and you can't filter out these excess ions, they build up in your blood, right? Or if you can't control how much water is in your body, then, you know, all these different things can become toxic. So these aren't toxins that they're filtering out, but all of these things can become toxic. One of the things that people who are in kidney failure often have to undergo is dialysis. And if you think of your kidney as just a filter, right? Your blood's coming into your kidney's filtering things out and sending that clean blood back to your heart. Dialysis is doing the same thing, only it's using a machine. So you go into a dialysis room at a hospital or a facility, and they are literally taking the blood from your body and pumping it through a machine that filters it and pumping that clean blood back into your body, because your kidneys aren't able to do that job anymore. Questions on any of that stuff? So once the kidneys have done their job, whatever gets filtered out, whatever waste product there is, travels through ureters. Ureters are the tubes that go from each kidney to your bladder. They're made of involuntary smooth muscle, right? There are two openings that go into your bladder at the back of your bladder, so that the urine travels down those tubes to go into your bladder. The inner layer is transitional epithelium, so they can stretch a little bit. The middle layer is smooth muscle, so very much like the smooth muscle that moves food through your digestive system, they squeeze to push the fluid along the way. And the outer layer is just connective tissue just to protect them. So the movement of urine is by peristalsis. It's the same mechanism that moves food through your digestive tract. And then we get to a point, right, where we start talking about conditions like kidney stones. Some people get kidney stones more often than others. If you think about what's happening in your kidneys are filtering out all these salts, right, and all this water. Well, what if you have a lot of salts in your blood, but not a lot of water? Well, what's going to end up sitting in that renal pelvis before it goes into the ureter is a lot of those ions, a lot of those salts. And if there's no water there, they can form little crystals, little rocks. And it can actually block your ureters, can block the flow of urine from the kidneys to the bladder. It can even reduce or prevent filtration depending on how far back the infection goes. So it's just kind of this, these normal salts that are there, but you end up without a lot of water. You end up just collecting those salts, and they turn to crystals, and they can block up those little tiny tubules. Now, usually what they do for somebody with kidney stones is they give you medication that will help pass those stones, right? They want you to pass them, so they kind of they give you a medication that kind of coats those calcium deposits so that they can pass a little bit easier. They can also use sonication, so it's almost like an ultrasound that will vibrate, and it'll kind of break up those stones into smaller pieces so that hopefully you can pass those. Last ditch effort would be to do surgery, but they don't like to do surgery unless you keep having this, this problem recurring with kidney stones, and you can't pass them, and that's restricting your kidneys from doing their jobs and passing urine to your bladder.
Now, are those the same holes that you were talking about before that the kidney stones have to pass through?
The same holes as what? I'm sorry.
The same holes that you were mentioning before, the proteins, if you have that are passed into your urine?
No. So the proteins would be too big to make it out of your bloodstream. They would be too big to make it out of the capillaries.
Okay.
This is once the filtrate gets filtered by the nephrons and it passes into the minor calyx and the major calyx of the renal pelvis. If it's sitting in that renal pelvis and there are a lot of salts and not a lot of water, those salts can start to crystallize.
Okay.
And so you end up with these little crystals trying to fit through those tiny little tubes called the ureters, and that doesn't work. That's what happens.
Trying to figure out what part we were at. Okay.
Right. So let me go back to kidney. Here we go. So it would be, these would be like right in this area here. You would
Okay.
get kidney stones. So as things are getting filtered through here, right, and they're in this kind of tan area, you would have a kidney stone that blocks the flow of fluid down the ureter.
Okay, I see. Thank you.
Welcome.
I have a question about the kidney stone.
Sure.
Can we really pass them? Like, can we see them?
Can you see them with your eye? Is that what you mean?
No. When I saw people, I heard people said that they eat too much spinach and they
Yeah.
have those pain, and they said they passed the kidney stone. And I
Yeah.
was like, wondering what it looks like, can they really like pass it, like, the tiny grain?
Yeah. It looks like a tiny grain that would come out in your urine.
Do you
They're
say eat too much
notoriously,
spinach? I'm sorry.
Yeah, that's what I heard.
No, I'd
Because
never
it's
heard that.
calcium. It's
Oh, okay.
calcium.
All right.
yeah, calcium deposits are a big one with stones. They say if you drink a lot of soda and stuff, that can give you stones as well, because it's dehydrating you. And
Oh.
you end up with a lot more, crystal salts and stuff in there. And some people are just more prone to it than others too. It's supposed to be one of the most painful things to pass a stone, and you can imagine if it's, it must feel like a huge stone because you're talking about a tiny little tube that it's got to go through.
That's why I'm curious, like how painful could that be?
It's supposed to be very painful. Luckily, I've never had to experience it, but it's supposed to be very painful. But like I said, doctors would rather try to get you to pass it than cut you open because of risk of infection and things like that. They don't like cutting people open if they don't have to.
Right.
Can magnesium salts build up just from taking magnesium supplement? Or is that like more excess in other ways?
So that's a good question. I don't know. I think it can build up. Like I know calcium deposits can build up from taking too many calcium supplements.
Okay.
So I would think the same is true with magnesium. Certain things like I take vitamin C, and vitamin C is not like that. Vitamin C you'll pass through your urine if you take extra because it's soluble. Whereas I think magnesium, I know calcium will build up. I think magnesium will build up like that as well. So you just have to make sure you're drinking plenty of, water. Like that's the other half of this. It's not just that you have the salt building up, but you don't have any water in your urine, right? If you think about if you're not drinking enough water, that nephron is causing the water to get reabsorbed into your bloodstream. The water's not getting passed to the collecting duct, and it's not getting passed to your urine. And so it's a combination of taking too many of these salts, but also not drinking enough water with them.
Okay.
Usually what leads to it.
So it sounds like the non-organic, like the minerals versus, like you were saying, the vitamin C. So that being organic, like that's because we can pass it through and our bodies
Right.
will get rid of it. Okay.
Right.
Thanks.
You're welcome. So here we go with the organs for conduction and storing urine. So over on the right here is the urinary bladder. You can see the two ureters coming in. They actually come in from behind the bladder. And the two openings are called the urethral orifices. You can see those two openings. So those tubes come down behind the bladder, and that's where they enter the bladder. And then where urine leaves the bladder, that's through the urethra down here at the bottom of this. I lost my cursor again. There we go. Down here at the bottom of this. And the two openings of the ureters and the opening of the urethra form a triangle, and that's called the trigone, that area. This happens to be a male bladder, so there's a prostate gland right there that the urethra passes through the prostate gland. Obviously in a female, that's not the case. And so over here on the side view, you can see the male and the female. You can see the ureter coming down. You can see this kind of pinkish organ here is the bladder, and you can see the prostate right below it. So the ureter leaves the bladder, it travels through the prostate and travels through the entire length of the penis before it exits the body. Whereas with the female, here's the bladder, right? And there is a short urethra that leads directly to the outside of the body. It doesn't pass through anything else really. So you guys have all probably heard of UTIs. Urinary tract infections are more common in females than they are in males. And one of the reasons is that the bladder is a really good environment for bacteria, right? It's the right warmth, the right temperature, the right moisture, all that kind of thing that bacteria really like it. Now, there are bacteria around us everywhere outside our body all the time. But one of the biggest reasons that this infection happens more in women than men, is just that the length of the urethra in a female is usually about 1 inch to 2 inches. And in a male, it's much further. In a male, the urethra actually has to travel all the way back up to here. So the bacteria would have to get all the way up this urethra to the bladder, whereas in a female, it's a much shorter distance to the bladder. That's the biggest reason that urinary tract infections happen much more in females than they do in males. And as I always like to point out with this picture of the female, here's the uterus. This is the organ that expands and holds a growing embryo, and you can see that it sits right on the bladder, right? And so that explains a lot of why pregnant women have to go to the bathroom a lot. There's a lot of pressure on their bladder all the time. So the bladder, right? We know what the bladder is. It's the hollow muscular organ that stores urine. The size varies with the amount of urine that's in it, obviously. And leaving the bladder is a tube called the urethra. The urethra has both an external and an internal sphincter muscle. The internal sphincter is actually smooth muscle, so it's involuntary. The external sphincter is skeletal muscle, so it is voluntary. That's the one that we learn to control as infants or toddlers. And so you can see here in males, the actual urethra is probably 7 or 8 inches long, whereas in females it's only about 1 inch long from the outside of the body to the bladder. And again, when we're talking about the kidneys and what they do, they're maintaining fluid balance, right, by maintaining how much water gets in and out of your blood, maintaining electrolyte balance. Electrolytes are just ions like sodium, potassium, and maintaining acid-base balance, because you are actually getting rid of some of these hydrogen ions in your urine as well. Okay. So there's a whole lot of detail to these 3 steps that we're not going into in our course this semester. Are there questions? What questions do you guys have for me about the urinary system? You guys are silent.
What did you say again about the voluntary and involuntary muscles?
So
Sorry.
no, that's fine. So leaving the bladder, going into the urethra, there are 2 muscles called sphincters. There's an internal urethral sphincter and an external urethral sphincter. The internal one is involuntary. And you cannot control that, right? It's smooth muscle. The external one is voluntary, it's skeletal muscle. So that's the external urethral sphincter is the one that you learn to control as a infant or a toddler, right? That's the one that you're learning to control. And that's the one that, sometimes elderly people become incontinent because skeletal muscle wears out after a while, and you can't necessarily control that the way that you would want to.
There's a medication, I can't remember what it's called, but a resident of mine was recently put on it for incontinence. I cannot remember what it's called, but how does that work?
I don't know.
No, okay. I wish I could remember what it was
I don't
called.
know if I don't know if it triggers a person to realize they have to void their bladder when the bladder is less full.
Yeah.
So that maybe, it doesn't get as full and doesn't cause that problem. I'm not sure.
Yeah. Okay. Interesting. I'll have to look that up.
Yeah, definitely.
I mean, there's a medication for everything. It's unbelievable.
Yeah, it is. It is. And when you start thinking about what those medications really do, sometimes it's what it's
Yeah.
being used for is like a side effect of what it really, you know.
Right, exactly. That's what we're talking about before. Like when you're talking about anal seepage, it's like that's
Yeah.
like every single medication side effect. It's crazy.
Yeah. Yeah,
Or
exactly.
death, or if you're allergic to this medication, don't take it. It's kind of funny.
Right, you're right. I know on those commercials all the time. If you're allergic to this
Uh,
medication, stop taking it. Well,
yeah, yeah.
if I was allergic to
Good
it, I
call.
wouldn't be
Yeah.
taking it, you know?
I have a question about, the prostate. As some people grow older, the prostate enlarge, and
Mhm.
which one is affected? Is it the external that get pinched, or that get squished by swollen prostate?
Yes, I think so. I'm just trying to go back to the slides here. So yeah, so what's happening is if we look over here, my slide won't move. Eh. So you can see here's the bladder, here's the prostate, right? There's the internal and the external sphincter. So I think it actually pushes against both of them. I think what's happening is it's when it's swollen, it pushes against your bladder, and that triggers a reflex that makes you feel like you have to urinate, even if you don't. Like it makes you feel like your bladder's full, because that's what triggers the feeling, is that the bladder fills up and stretches. I'm sorry, you can't see any of that, can you?
No.
I forgot to share it. So what happens is the bladder fills up and stretches, and all right, here we go. So the bladder will fill up and stretch and push against the internal sphincter and the external sphincter, and it tells you have to void your bladder. And so if the prostate is swollen, it's pushing against the bladder. And I think what it does is it triggers the reflex that you have to void your bladder, even if you don't necessarily have to, right? And at the same time, it's pinching both the internal sphincter and the external one, so that you're not able to void it as you should.
Okay, so that's where they put the urinary catheter, right there where the center of the trigone is.
Mm-hmm. Yep.
Okay, I see. Okay, thank you.
You're welcome.
And the feeling to urinate is only from the stretch receptors, nothing to do with any sort of hormones or anything?
Right.
Okay,
Right.
so that wouldn't be
just-
the answer to the question of the medication.
Right.
So,
Right.
yeah. Interesting.
Other questions? What I am going to do then is open up the next slides. So we're going to start talking about the reproductive system, because we have, what, half hour today, and then we only have an hour tomorrow. So, reproductive system. So what's the point of the reproductive system?
To reproduce.
Reproduce. Good. So we'll talk about it in terms of male and female reproductive system. The goal of the male reproductive system is to produce sperm and to deliver them to the female. The goal of the female reproductive system is to produce eggs, but also to nourish a growing embryo for 40 weeks, right? So the female's body has a lot more to do, right? There's a lot more that goes on, because not only does the female body have to produce a viable egg, but it has to nourish an embryo for the pregnancy, for the 40 weeks that she's pregnant. So the reproductive system ensures continued existence of the species, produces, stores, nourishes, and transports reproductive cells or gametes. So gametes, when you see the word gametes, those are reproductive cells. That either means egg or sperm. Okay, and you probably hear all the time that, well, sexual reproduction offers more genetic variation, right? The advantage to that is genetic variation. Well, what does that mean? Like, why don't we just, bacteria just bud into two new bacteria cells? Like why does reproduction ensure more genetic variation? What does it do?
Takes the genetic codes from two different people. Is that what you mean?
Yeah, so
Okay.
if we think about this, right, we have how many, do you guys know how many chromosomes we have in a cell?
Is that
Anybody?
13,
30.
13 for each?
Yeah.
No, not 13.
32,
No, more than that.
36.
More than that.
Wow,
46.
40,
We have
46.
46 chromosomes. So
Oh,
all of our cells
46.
have 46 chromosomes. We get 23 from our mother and 23 from our father. But our mother had 46 chromosomes and our father had 46 chromosomes. So there's this genetic diversity, right? None of us are exactly like our mother or exactly like our father, right? We get half our traits from one and half our traits from the other. And your siblings, your brothers and sisters, got a different combination of 46, right? They probably didn't get the same 23 from your mom and the same 23 from your dad that you did. So this ensures all this genetic diversity. It ensures that any genes that we have that are, going to lead to certain diseases or certain disorders don't necessarily get passed on every time two people reproduce, right? They might only get passed on once in a while to certain offspring. It allows for this huge amount of genetic diversity. There are none of us that are genetically identical. And even identical twins may not be 100% genetically identical. There's actually a lot of cool studies about that. So the reason that we gain this diversity is that, okay, our mother has 46 chromosomes. She's passing 23 on to us. Our father had 46 chromosomes. He's passing 23 on to us. So now we have 46. But my brother and my sister probably have a different 46, right? And then I have 3 kids. I doubt then any of them got the same 23 from me, so it just continues this genetic diversity. So that's the reason for sexual reproduction. That's the reason why it has stuck around, and that's the reason why so many species successfully reproduce that way. So when we're talking about the reproductive system, gametes just mean sex cells. They mean either sperm or egg. The structures that produce those gametes are called gonads. Okay. Not only do they produce gametes, but they produce hormones. So in the male, that's the testes. Those produce testosterone as a hormone, and they produce sperm. In a female, that's her ovaries, and the ovaries produce the egg, and they produce estrogen and progesterone. Okay. Then, and then going from those gonads, there are ducts to receive and transport the gametes, which form part of the reproductive tract, right? So there's different names for those in males and females, but those are the ducts, the tubes that the gametes travel down through. And then there are accessory glands that we'll see that secrete fluids into the ducts. So we'll go through all of these. Okay. Again, gametes are just sperm or egg, right? They're called sperm in males, produced by the testes, and the testes also secrete testosterone, which is an androgen. In the female, the egg is called an oocyte or an oocyte. I've heard it pronounced both ways. Those are produced by the ovaries. The ovaries also secrete estrogen and progesterone. And an oocyte is an immature gamete, and when it becomes fertilized, it's called an ovum. Okay? So there is this kind of path that the gametes follow, right? They are produced in the testes. They travel through a series of ducts, and the order goes from epididymis to ductus deferens to ejaculatory duct to urethra. And all throughout that way, there are accessory organs that secrete products into that duct, the seminal glands, the prostate, and the bulbourethra. Okay, and so we will get to this diagram. It's a little bit easier to see in this diagram. So here is the testing, right? This is where sperm cell production is happening. Once the sperm is produced, it travels through this duct, right, to get out of the body. Now that duct has several different parts that have different names. Okay, kind of adjacent to the sperm, when the sperm are immature, they stay in the epididymis, and they travel through this duct, which is called the ductus deferens, or the vas deferens, same thing. The vas deferens passes by those accessory glands that we were talking about. Here are the seminal glands. Oh, I lost it. Here are the seminal glands. Here's the prostate gland, and here's the bulbourethral gland. We have 2 seminal glands, one on each side, just one prostate in the middle, and then 2 bulbourethral glands. And this tube after the bulbourethral gland is the urethra, right? And so the male reproductive system is different than the female in that the exit for the male reproductive system is the urethra, which is the same as the exit for the urinary system, which there's 2 different exits, obviously, in the female reproductive system. Okay, so what you need to know is that in the testes is where sperm is produced. It stays in the epididymis, travels up through the ductus deferens, which you can see travels by the urinary bladder here, travels by the seminal vesicles. It travels through the prostate gland, kind of a tunnel right through the prostate gland. And that tube, when it's in the prostate gland, is called the ejaculatory duct. It's the same tube, right? It's just given a different name because of where it is. And then once it leaves the prostate gland, it is the urethra, right? That tube is the urethra. And you've got the bulbourethral gland secreting things into the urethra. And the urethra is the tube that leaves the body through the penis. Questions about any of that so far? So the sperm production that happens in the testes. In the testes, if you were to open up the testes, there's a bunch of coiled up little tubes, kind of like spaghetti, coiled up like spaghetti, called seminiferous tubules. And so here they are here, right? So this is a testes cut open. You've got all these coiled up tubes. Those coiled up tubes are called seminiferous tubules. That's where sperm production actually takes place. That's where the cells actually divide by a process called meiosis that we'll talk about, and travel then through to the epididymis, through the ductus deferens, et cetera, et cetera. This is a section through one of those tubules, right? So over here you can see these are the tubules all coiled up. So look, think of these as like straws or as tubules coming out of the board towards you, right? So each one of these purple structures is a different tubule. And inside the tubule are the cells that will become the sperm. And so what they're doing is just looking at one tubule here, okay? The cells that are not quite divided yet, those are around the edge. And as they divide, they move closer and closer to the center. So at the center of each of these tubules is the lumen. Okay, the lumen is the space. So think of that as the hole going through the straw. So as these cells divide, as they become sperm, they get closer and closer to the center. And you can see that the actual sperm, the fully formed sperm, are close to the center. And that makes sense because then they can travel through that lumen, through that space to get to where they need to go, right? So the ones that are around the edge, they're still kind of attached to some tissue here at the edge. And as they start dividing, they're moving towards the center. Once they become fully formed sperm with a tail, they're all the way at the center, which is the lumen, and then they can swim to their destination. And if you look in some of these, like inside this seminiferous tubule, if I can zoom in on it maybe, you can see that at the center of it, there are sperm. You can see these little structures, these little tail-like structures. Whereas this one looks empty, right? Because it's only got the early spermatids around the edge. This one has a bunch of tails in the middle, so this has fully formed sperm in it. Okay. Spermatogenesis is the production of sperm, right? Spermatogenesis begins at puberty and continues till late in life, sometime after 70 probably. So males don't start producing sperm until they hit puberty, until they get that influx of testosterone. Requires a series of cell divisions in those seminiferous tubules, so inside the testes, and each division produces a daughter cell that's pushed towards the lumen, towards the center of the tube. It involves its mitosis at the beginning, then it changes to meiosis. I'm not going to get into a whole lot of the difference between mitosis and meiosis. And here's what's going on. So you start with a very early spermatogonium, which then becomes a primary spermatocyte, which starts to undergo meiosis and becomes a secondary spermatocyte. And then once it undergoes a second round of meiosis, it becomes a spermatid, and you can get fully formed sperm out of this. The thing to remember is that one spermatogonium produces 4 sperm, right? Because it's 2 rounds of division. So instead of one cell becoming 2, it's 1 becoming 4. Okay, and so if we're talking about this in terms of chromosome number, this cell here has 46 chromosomes. We know that, right? All of our cells have 46 chromosomes. When it goes from here to here, all those chromosomes double. So here, it really has 92 chromosomes. So this big cell, this primary spermatocyte, has 92 chromosomes. It splits into 2 cells. Each of these have 46 chromosomes, right? Each of these have, if you look at the center, they look the same as this. And then each of these splits again, so that each of these cells only has 23 chromosomes. And that's what the sperm become. The sperm only have 23 chromosomes, right? Because you need a sperm with 23 chromosomes to fertilize an egg with 23 chromosomes, so that you get one fertilized cell that has 46. Right? So this is the process where the cells go from having 46 chromosomes to only 23. And in the male, the only ones that have 23 are the sperm. And in the female, the only ones that have 23 are the egg. Right? All the rest of our cells have 46 chromosomes. So this division is the division of where you go from having a cell with 46 chromosomes to having 4 cells, each only with 23 chromosomes.
Can I ask a question while we're on that page?
Sure.
You're talking about the chromosomes. I heard about this X, which sperm is carrying X, which is carrying Y. Are they both carrying X? I don't know.
So, right. So we have 23 pairs of chromosomes. We have 46 chromosomes. We get 23 from mom, 23 from dad, right? 23 pairs.
Right.
And all those pairs are just numbered 1, 2, 3, all the way up to 22. The 23rd pair are called the sex chromosomes.
Right.
And if you're genetically female at birth, you have 2 X chromosomes.
Mm-hmm.
If you are genetically male at birth, you have an X chromosome and a Y chromosome. So when your mother produces an egg, right, she has 46 chromosomes. She's going to give 23 to the egg.
Mm-hmm.
When it comes to that 23rd pair, it has to be an X from the mother,
Always,
right? She has 2
Always
copies of the
X.
X, always an X. When the male produces sperm, some of the sperm are going to have the X and some of the sperm are going to have the Y, right? Because remember, a male has an X and a Y. So some of the sperm are carrying an X chromosome and some are carrying a Y chromosome.
Oh, okay.
That's why they say when a woman gets pregnant, the gender of the embryo is based on the male, right? Because it's based on whether
Mhm.
his sperm are carrying an X or a Y. And there are labs that purport to be able to separate the sperm based on weight,
Right.
because the X chromosome is significantly bigger than the Y chromosome. It would weigh more. And
Mhm.
so the theory is that if you can separate the sperm into two weight classes, and the ones that are carrying more weight are the ones with the X chromosome, and the ones that are carrying less weight are the Y chromosome, then you could potentially use whichever you wanted to potentially have either a male or a female baby, like
Mhm.
they're doing in vitro fertilization. I don't know if I totally believe that labs can do that. I mean, there is, right, there's scientific reason to understand why one would weigh more than the other. I just don't know if you can actually separate that down to that weight. But there are labs that claim that they can do that.
So it's only by weight, like the difference between the X and the Y chromosome would only be a weight factor, no visual factors or anything like that.
Oh yeah, visually they look different, but I don't know. The least invasive way that you can separate them would be by weight, right? The only way that you could do that visually is to actually kill the sperm and crack it open and see what it has. But at that point, you can't use that sperm to fertilize anything because you killed it. Like you can't, you
Mm.
know what I mean? Like you can't, yeah. So,
There's no way to force a girl if you want a girl or anything like
well,
that.
I mean, theoretically there is, right? Theoretically, you can tell labs can tell the difference between a sperm carrying an X chromosome and a sperm carrying a Y chromosome.
Or like stand on your head during a full moon or something, you know?
Right, exactly. Drink some sort of solution, some sort of homemade solution. I mean, I don't know. I think there's got to be other things that affect the weight of the sperm. Like I can't imagine that all sperm weigh exactly the same amount, other than what's accounted for by that one chromosome.
Yeah,
You know?
what I read is they said the X is denser
Mhm.
and slow swimmer than the Y. That's why the Y get to their target first. And
Mhm.
if the ovulation happened 3 days later or later on, chances of female is high because the Y already passed it or dead. Or
Oh, yeah. I mean, there's. Do you believe that?
I don't know.
How do how can you even
The
prove
difference
something
in
like that?
weight
There's
has
so
to
many.
be like ridiculously like close, you know?
Oh yeah, it would have to be
Yeah.
microns.
Wow. I'd never heard that. That's interesting though. Never
Yeah, I mean
know.
Yeah.
that's how they're doing it, and that does make sense, Juliet. That the lighter sperm would get to their target faster. They'd be able to swim faster because they're lighter.
Right.
But then how do you? I mean, you're always estimating. Okay, I think the person, the woman's like, well, I think I'm ovulating at this time. Like, you take a test and you have certain hormones when you're ovulating, but there's a window there, and I don't know. It's just I can't imagine it working successfully very often. I think
It's a
it's more
timing.
just a chance. Right.
Right, it's a timing of ovulation. We can't really tell when the ovulation happens, but yeah, they said frequent, you're more like frequent intercourse, so you're more likely to get a girl.
Mhm.
But no, frequent, you're more likely to get a boy because it's flooded with fast swimmer, and
Right.
then less, you're more likely to get a girl because the slow
The fast
swimmer
ones
is
have already
still
missed.
72 hours. Yeah.
Yeah.
That's a theory, but we don't
Yeah.
really know.
Yeah. I mean, I could see the theory behind that. It would be really hard to put that into practice and with any kind of reliability,
Right.
you know.
Hit and miss.
Right.
Hi, thank you.
Exactly. The structure of the sperm, we'll go through this a little bit because it comes into play in a little while. So that, we all know what a sperm looks like a tadpole. They have a head, a middle piece, and a tail. The head has a piece at the very tip called the acrosome. Acrosome is full of enzymes. And the reason for it, does anybody know why the tip, the head of the sperm, has a bunch of enzymes on it?
Is that for protection on
Nope.
acid? No?
And
Not
for once it gets to the egg.
Yes. So the egg has a layer of protein surrounding it, protecting it. And the sperm has to kind of burrow a hole through that protective layer to reach the egg, to fertilize the egg. And that's what these enzymes do. They kind of degrade that outer layer. The nucleus is the part that contains the 23 chromosomes. And then you have the mitochondrial spiral. Does anybody remember what mitochondria do?
That's
It-
the one that produces ATP for that they
Yep.
can swim faster.
Yep. See, I knew I'd get ATP in there somewhere.
I was just gonna say that.
They produce ATP. And so this tail that moves back and forth there has to be a lot of energy to move that tail back and forth. So the sperm actually have a lot of mitochondria so that they can flip that tail back and forth to swim. All right. So we talked about the sperm production in the seminiferous tubules, which are in the testes. Attached to the testes is the epididymis, and the epididymis kind of is where the sperm kind of they kind of collect there until they're kind of mature to travel on their way. It recycles some damaged sperm, so it kind of filters out any sperm that don't look like they could actually fertilize an egg. And then once the sperm are mature, they travel through the epididymis and they move into the ductus deferens, which is sometimes called the vas deferens, the same thing. So the sperm that move into this ductus deferens, they're more physically mature. They're not mobile yet. Okay. And so they move into this vas deferens and they are propelled by peristalsis. So the same thing that moved urine through the ureters, the same thing that moved food through the digestive cavity, system, are these smooth muscle contractions that push the sperm along. Okay, and so I showed you where that ductus runs. Now the first thing that runs past is something called the seminal gland. Right, these are the accessory glands. The accessory glands are the seminal glands, the prostate gland, and the bulbourethral gland. And they are producing the fluid content. So they're producing the semen. So right now, all you've done is produce the sperm. All the male has done is produce the sperm. There's no semen. There's no liquid for that sperm. And so when you get to these accessory glands, they produce parts of the semen. And the first set of accessory glands are called seminal glands. They're paired. You have two of them, a right and a left. They contribute about 60% of the volume of the semen. Their secretion is slightly alkaline, okay, slightly basic. And that's because there are acids in the prostate and there are acids in the vagina, so it's got to kind of buffer that. They also secrete fructose. A huge part of what's in our semen is fructose. The reason for that is because remember all those mitochondria that are in each sperm? Those mitochondria need sugar in order to produce ATP. And so this gland, one of its main things that it's contributing is that it's contributing sugar so that the sperm have a way of making energy to travel along that route, right? Because they not only have to travel all the way through the ductus deferens and the urethra, but they have to travel up the vagina into the fallopian tubes in order to fertilize an egg. Okay, they also secrete prostaglandins, which stimulate smooth muscle. Again, that makes the sperm move more. And fibrinogen, that forms temporary semen clot in the vagina so that it can stay there longer, basically. So this is when the sperm begin becoming motile, right? Up until then, it was that tube that was squeezing and pushing the sperm along. Now they actually have a source of energy. They can begin using their tails and becoming mobile. And then they're going to pass through the prostate gland. Remember, there's a tube that goes right through the prostate gland. It's called the ejaculatory duct. The prostate makes up about 20 to 30% of the volume of semen. It contains what's called seminal plasmin, which is an antibiotic, right? It helps to prevent urinary tract infections. It kind of clears the male urethra in a lot of ways, because remember, the male urethra is the exit of urinary system and reproductive system. So it's kind of clearing out anything so that you don't necessarily have any bacterial infections. And again, there's peristalsis going on in the prostate to help propel those secretions into the urethra. And then finally, you get to a third set of glands called the bulba urethral glands. They're also called Cowper's glands. Again, these are paired. They're on the right and left sides. They're located right at the base of the penis, and they contribute to less than 5% of the semen. They secrete a thick alkaline mucus, so they're helping to neutralize urinary acids in the urethra. Again, all these acids that are being filtered out by your kidneys that are traveling through the urethra have to get neutralized, or else they can actually degrade the sperm. It also lubricates the glans penis, or the tip of the penis, contributing to the sperm, or allowing the sperm to reach the fallopian tubes better. Okay. So what I'm going to do is stop there. It's about 3 o'clock. I'll stop there for today, and I'll ask you guys if you have any questions.
Good question. What is a lower, they said the lower semen means it's like people can't reproduce because they have lower sperm count?
Lower sperm count. So we produce, I don't even know how many millions of sperm a day males produce, but there could be reasons that your body's not producing as many. Could be, medications, it could be genetic reasons, whatever. And so what they can measure is actually, a doctor can measure, can take a sample from a man and measure how many sperm are in an ejaculatory fluid, a certain amount of ejaculatory fluid, and can determine if the male has low numbers of sperm. So if it's lower than the average, then there's going to be a lesser chance of the man getting a female pregnant, right? So a lot of times if couples are having trouble getting pregnant, that's one of the things that they might go to a doctor and look at. Well, is the male producing less sperm? Is there something that he can be given, a certain medication or a certain drug that they can be given to increase the amount of sperm production? So it's just increasing the odds, right? You're talking about millions of sperm, and the odds of any of them getting to an egg in the fallopian tube and fertilizing that fallopian tube are pretty slim. When you'll see when we start talking more and more about this tomorrow, the chances that reproduction happen so frequently and so successfully are kind of amazing.
Okay.
Yeah.
All right. I'll look into it tomorrow. Thank
Will
you.
you be
You're welcome.
posting that video? I have to work, of course, naturally.
Yeah.
So will you be posting that video? Because I'm really curious. I'm really interested in this
Absolutely.
part. Okay, awesome. And so with that said, thank you for everything. And it was really nice to have class with all of you guys.
Thank
It
you.
was I can't make tomorrow either, so this is my goodbye too. It's been awesome. It's been awesome. Thank you very much.
Thank you. I had a lot of
I
fun
didn't
this
even
semester.
realize that. That's so sad. Oh God. Wow.
Aw.
Yep.
You guys
Well,
too.
Well, I had a lot of fun this semester, and I'm glad most of you, you put your cameras on and you participate, and we never know what to expect with an online class. And I thought this was a really fun class, so I'm glad I was here too.
I sadly finally got rid of all of my dissections yesterday.
Aw.
I did a full-blown house cleaning, and I was like, okay, at the end of the semester, you can say goodbye to everything. My playroom smelled like embalming fluid. It was so bad. I was like, these poor kids are never gonna play in here again if I don't get rid of this stuff. Okay.
Thank you again.
You're welcome.